Okay, so we'll go ahead and get started. That first part was really to lay down the roadmap, and you can see, get a lay of the land and what the issues are in terms of the high rates of use, the really significant health consequences, and what's kind of been in place to maintain tobacco use among the populations with which we work. The second part is going to get into, all right, now what do you do about it? How do you assess tobacco use with the clients that you're working with? What treatment has been shown to work? What's available? How can you link with referrals? And then we'll get into organizational systems issues and some consideration there. And there are a number of cases that I have, case examples. Some of them are real, some of them are those that we create, and we've used them with trainings that we do with mental health providers. And so we can have that be much more interactive with getting ideas from you all and how you would work with these different complex cases around tobacco use. Any questions from the initial part on what was presented earlier? I will address the weight gain concern because that was something I'd say I don't have. But weight gain concerns, can be really substantial with some individuals. Particularly, women may be more sensitive to it. Also, there's groups that show higher risks of increased weight gain following cessation. African Americans at higher risk for that. Those who are already overweight, higher risk with that. What does the literature show? Well, on average, smokers tend to weigh less than non-smokers. Okay, and on average, when a smoker quits, they go up to the weight that they would have been as a non-smoker. What is going on there with the weight gain? Some of it is that nicotine induces metabolism, so it speeds up an individual's metabolism. So that's why they're at a lower body weight to begin with when they're smoking versus not smoking. Also, when an individual quits smoking, so they've got their metabolism getting normalized, they also have their sense of smell, sense of taste becomes normalized. So now that they can taste food, smell food, it becomes more pleasurable to eat. So you want to educate them around that. Also, that hand-to-mouth ritual, they're used to having that cigarette, and next thing you know, they might be putting chips or other high-fat, salty food instead of the cigarette. And so you want to talk with them around healthier food choices like carrot sticks or using a toothpick or a straw, doodling, keeping their hands busy, drinking water, and that kind of thing. Sugar-free gum can be some different substitutes instead of food. You don't want the individual to be focused on their weight when they're trying to quit smoking because it's actually been shown to lead to relapse. So if they're constantly getting on the scale or really restricting their calories, they're more likely to fail at quitting smoking. And so you'd want to educate them then that tobacco is much more serious cardiovascular risk, cancer risk than some weight gain. And so you really want them to prioritize quitting smoking at this time. And then there are medications that have been shown to help delay weight gain associated with quitting smoking. Both nicotine gum and bupropion or Zyban has been shown to help delay weight gain. So that can be useful. And exercise is really, really, really valuable for weight management, mood management, stress, also dealing with cravings. So there's been a number of lab studies showing that if people are trying to quit smoking and they get into a lab and do exercise, it's a very effective way for dealing with craving and withdrawal. So, talking with your patients about going out for brisk walking and so on can be really helpful. Okay? Good. So, recommendations to treat tobacco use in psychiatry. John Hughes, he's a psychiatrist, he's a professor at University of Vermont. This is a quote from him. In terms of lives saved, quality of life, and cost efficacy, treating smoking is considered the most important activity a clinician can do. So, it's cost effective, not only save lives in terms of years of life, but also quality of life. Your patients may say, well, you know what, I don't care if I die younger as long as I was able to smoke. It's not that they just suddenly die from their tobacco use, but a number of quality of life issues that are going to come up. They can't take the stairs like they used to. They can't keep up with their grandchildren. They just can't get around. They're not physically functioning like they would if they were to quit smoking. Tobacco treatment guidelines. All patients ought to be screened for tobacco use, advised to quit, and offered intervention. This is recommended by the American Psychiatric Association as well as U.S. Public Health Service. All patients should be offered pharmacological treatment for quitting smoking unless it's contraindicated. And there's a dose-response relationship with the amount of contact provided. Today I won't go into a lot of detail on the different pharmacotherapies that are available for quitting smoking. There is a handout in your materials that's a really nice summary of the different medications that are available, what the product is, what the precautions are, how you dose it, and then adverse effects, advantages, disadvantages, and cost. So it's a real handy one-pager to have as a resource for cessation medications. The dose-response relationship, it's been shown that the number of sessions at which tobacco is addressed with a patient, the greater the number, the greater the likelihood that they'll be quit. This is at 5 months or more post-cessation. So the more times that you can just bring up tobacco with your patients, planting that seed, letting them know that it's an important issue relevant to their clinical care, the more likely that they're going to build awareness and start thinking, well, hey, you know, they keep asking me about this. Maybe it is something that I should consider to do. How do I get help? And, you know, getting them to move forward in their motivation for addressing tobacco. The number of clinicians can make a difference too. So if you're working with a team, and most of us work in teams, having the different team members address tobacco, having it be that consistent message so that they're hearing it from more than one individual, that increases the likelihood that they'll quit as well. So twofold greater increase in quitting if they're addressed for tobacco by at least 2 people. The National Cancer Institute came up with the 5 A's as a handy way to remember how to address tobacco. The first one is that you ask about tobacco use with all of your patients. And then for those who you identify as smokers, that you advise them to quit smoking. You assess their readiness to make a quit attempt. You provide assistance with the quit attempt. And you arrange follow-up. With asking about tobacco use, you can asking broadly about any form of tobacco. Do you ever smoke or use any type of tobacco? Letting your patients know, I take the time to ask all my clients about tobacco use because it's important. And that tobacco use and mental health status should be included in the intake assessment and documented for every client. So having that on the intake form is really, really critical. If it's not yet on your intake form, you know, that would be the first step to take, is just to get more awareness in your clinical setting about the rates of tobacco use among the patients that you're treating. And I'll give an example of a sticker that we created for our setting for increasing rates. And then I do work sometimes, so I'm working now with behavioral health providers who may not know as much about tobacco. Sometimes I work with tobacco people who don't know as much about behavioral health. So I had some items about assessing mental health issues, but I'm sure you all already do this. Raising awareness. For those who aren't ready to quit smoking, we have these little booklets that are about the size of a pack of cigarettes, and we have them carry this around to track their cigarettes, their pleasant activities, and their mood. And this gives us a good baseline assessment of what's going on here. How much are they smoking? What's their mood like? And how many pleasant activities are they engaging in a day? And we look to see if there's any relationship between those 2 things. So here they would do a check mark for every cigarette smoked in a day, check off for every pleasant activity they did, whether it's listening to music, going to the movie, talking with a friend on the phone, and then circling the face for their mood for the day. So here you might see, okay, well, when I isolated that day, I didn't get out of my house or do any activities, my mood was terrible, and I smoked a ton. Okay? And we have these, you can actually print this out from the RX for Change website, which is at the end. It's free, available to anybody. We have this, and you can print it out if you ever want to make a similar, but you can, definitely do this however you might like to do it with your patients. And patients, they might say, I only smoke half a pack a day. And yet when they start to really check it off, like, wow, I smoked more than I thought I did. Or, I found that I was smoking 3 cigarettes in the afternoon. I didn't even really need those cigarettes. I don't even know why I was having them. So it helps to build awareness simply through the act of tracking their use of tobacco. Advising tobacco users to quit. You want this to be a clear, strong, personalized, sensitive message. When I worked with psychiatry residents, as I was sharing initially, they didn't want to go near there. Like, many of them were psychodynamically trained, and they couldn't imagine how you would give such a, to make advice and to have such a statement that would, tell them how to change their behavior, what they should be doing, kind of thing. And concerns about the rapport with the patient. Well, if I'm telling them that they're doing something that's bad for them, are they going to want to come back and see me? Are they going to like me? Kind of thing. So, but you can do this in a very personalized, sensitive way. It's actually been shown that if a physician doesn't talk about tobacco with the patient, it actually, the patient expects them to, knows that tobacco is bad for them, and to hear a message that the physician's concerned about their health and that they should quit smoking actually builds rapport. So you're reaching out to the patient and letting them know, I'm concerned about you. You're doing a risk behavior that's not good for your health, whether it's mental health or physical health. And I'm concerned about this, and I would recommend that you quit smoking. Letting them know that you're trained to address tobacco and that you're available to them as a resource when they're ready. So quitting smoking, most important thing you can do to protect your health now and in the future is one message. I have training to help my clients quit. When you're ready, I can work with you to design a specialized treatment plan. If you're interested, we can work together to help you quit smoking and manage your mood and stress at the same time. Letting them know it can be very collaborative. With the patients, the initial survey that we saw from the AAMC, it said psychiatrists, 60% of them said that they ask about tobacco use. 60% said that they advise their patients to quit. When we've done surveys with patients, over half who had been, and many of them, just through the mental health system time and time again, they said they'd never been advised to quit by a mental health care provider. So you may be the first person who ever brings this up with them, and it will demonstrate how much you care about them and their health and their well-being. With mental health and addiction treatment providers, it's critical that you get on board with treating tobacco. You know the client well. You see them regularly over time. You should be aware of changes in tobacco status that may impact psychiatric medication levels. And then you'd be available to identify and address any changes in psych symptoms during the quit attempt. So if they're having more stress or anxiety or depressed mood, whether it's related to quitting smoking or whether it's just part of their time course with their disorder, you're able to work with them, be flexible with them, and help them through that process. And when it's on the other side, when you're saying, oh, don't quit, you're too stressed out, you're not ready, it sets up a message that it's not going to help them, because the patients are going to feel hopeless and helpless and not feel like they can't do it because they're getting messages that they can't from their providers. Another individual in one of my studies, talking with her, she said, you know what, I was told by my provider I'm too stressed out to quit smoking. Well, 43 years later, I'm still stressed out and I'm still smoking. Okay? There may not be any optimal, best possible time for quitting smoking with the patients that we see, because they deal with a lot in their lives. But let's not assume that they're not ready. Let's hear from them, and if they're ready, then providing intervention. Assessing readiness to make a quit attempt. This can be conceptualized in different ways. My father is James Prochaska. He developed the Stages of Change model, which considers people moving through different stages of change and making a change in their behavior. Been labeled pre-contemplation, contemplation, preparation, action, and maintenance. The significance of the model, we used to assume that people were either ready to quit or not. And that if they were ready to quit, well, then we provided intervention. And if they weren't ready, well, then we just let them become ready on their own at some point. And smoking cessation counselors, they set up their clinics and they just waited for those in preparation to come to them to be ready to quit. What we know from research, both in the U.S., outside of the U.S., is that only about 25% or 20% of smokers are ready to quit right now. And if we only offer ready-to-quit interventions, we're going to miss the majority of smokers, about 80% of them. So instead, the model breaks it down into different places based on their intention to quit, their readiness to quit, provides different interventions to move them forward on this continuum, to get them, to help them along the way, to help them get ready to quit, and then ultimately to quit smoking. This model applies to a number of different risk behaviors, not only tobacco, drug addiction, physical activity, diet, mammography screening. So once you learn this, it can be helpful in other ways if you find it useful. Those in preparation, these are individuals who are ready to quit in the next 30 days. Okay, and we'll talk about what you would do with them. In terms of, these are the individuals that you want to give your prescriptions for cessation medication, get a quit plan on board, and so on. Contemplation, these are individuals who are thinking about quitting in the next 6 months, but not in the next 30 days. They are aware that there's a problem there. They know that smoking is bad for them, but they see a lot of barriers in the way. So they're contemplating quitting because they know it's not good for them, and yet it seems overwhelming because they're concerned maybe about weight gain or stress or cost of treatment or not having social support, that kind of thing. Pre-contemplators, these are individuals who are just not thinking about quitting in the near future. So they're not thinking about quitting in the next 6 months. There may be a number of reasons why they're pre-contemplators. It could be that they don't know tobacco is bad for them, although in this day and age, that's getting to be a really small group. It could be that they tried to quit in the past and they feel demoralized, that they just couldn't do it. Maybe they didn't have treatment on board. Maybe it was a cold turkey attempt, or maybe they didn't have enough nicotine replacement. Or maybe their lives were, the living situation wasn't conducive for quitting smoking. It may be that for pre-contemplators, they may just find their cigarettes so enjoyable, the benefits of smoking are just too high that they don't see the negative effects as relevant. And so you need kind of a shifting of the benefits, pros and cons of smoking to help them move forward in becoming more motivated to quit. Action are individuals who've been quit, they're smoke-free, but for less than 6 months, so they're still very much at risk of relapse, and you want to work with them to avoid relapse. And then maintenance, they've been quit for at least 6 months, less risk of relapse, but you still want to really support them in living and sustaining a smoke-free life. One of the initial barriers that was in that AAMC survey with psychiatrists is this belief that, well, our patients don't want to quit smoking anyway, so why bring it up? You know, if they want to quit, they would ask me how to quit. And there's been a number of studies now. So these are the rates in the general population. About 20% in the general population, so smokers without mental illness, say that they want to quit in the next 30 days. 40% say that they want to, these are preparation. 40% say they intend to quit in the next 6 months. Those are contemplators. So a total about 60% who say they are interested in quitting smoking, 60 to 70% depending on the studies. We've done studies in general psychiatric outpatients, depressed outpatients, psychiatric inpatients. Another group did a study in methadone clients, all showing very similar rates in terms of the proportion who are in preparation, ready to quit in the next 30 days. Very similar rates in terms of the other group, those who are intending to quit in the next 6 months. So generally about 60 to 70% saying they are interested in intending to quit in the near future, in the next 6 months, with no difference based on whether they have mental illness or not. Further, we've looked to see, well, maybe it's the severity of mental illness. Maybe those with really severe depression or really severe anxiety or PTSD symptoms, maybe they're the ones that are not ready to quit. And there's actually no relationship there either. So even though, you know, it might seem to make sense as a clinician, well, look, the depression's really severe. Why would I possibly bring up quitting smoking? You know, listen to the patient. They may be ready, and meet them where they're at. The work that I do, I've worked now with over 800 hospitalized psychiatric patients. Okay, we go in acute psychiatric setting, high rates of suicidality, some homicidality, gravely disabled, and we're offering tobacco cessation. And patients are taking it, and they're using it, and they're quitting at rates similar to the general population, and I'll show some of those data. With assisting patients, you're going to tailor it based on their readiness. So does the patient now use tobacco? If yes, is the patient now ready to quit? If no, that's where you're going to promote motivation. If they're ready to quit, let's go forward, provide treatment, let's go. You know, they're ready, let's meet them there. If the patient does not now use tobacco, did they once before? If yes, you want to prevent relapse. If no, you want to encourage continued abstinence. And I'll share some literature on both of those. I don't have too much in here about the how-tos of quitting smoking. I have more about the evidence base to show you what's been shown in the evidence and to give optimism that our clients can quit, because I expect that many of you will refer to the ASH line. But I will show one strategy here about promoting motivation, because I think it's an easy, quick tool that can be used with your clients to help get them to start that dialogue, have some open questions, to start the dialogue to get them thinking about the idea of quitting smoking. So people here trained in motivational interviewing at all? Yes, okay, great. So everything you've ever learned about counseling clients on drug addiction, other drugs of abuse, some training there, all of that can apply to tobacco. You're really just substituting alcohol or drug with tobacco. You've got the skill set, you've got, you know, the tools to work with these clients, and it's just substituting in the word tobacco. These are two questions that are from motivational interviewing. The first one, how interested are you in quitting smoking now? Okay, does anybody want to play my smoker patient? Quick role play. It's not too painful, I promise. Okay. How interested are you in quitting smoking now? From a scale of 0, not at all interested, to 10 being completely interested. A 0? Oh, you want to be really, really tough. What would it take to get you to move forward on that scale? Okay, so you need support to become interested. That's an area that you're not feeling it. Great, okay. Anything else that would help? Okay, so getting some cessation medications. If you knew that there was a drug, a pill that would help you quit smoking, then maybe you'd be interested. Okay, I'm seeing nodding head for those who are viewing elsewhere. Great. So it's an open-ended question. It's a way to see, okay, well, what's missing from them? What would it take? And some may say, you know what, doc, if you could give me a magic pill, then I would go for it. Oh, well, do you know that there are cessation medications? Let's talk about what's available. Okay, or social support. I don't have any social support on board. Well, did you know that there's a quit line that you can call where you can get support, 24 hours or however many hours a day that's available now in Arizona to get that built in? Great. Anybody who wants to be a little bit higher than 0? Is that back there? Okay. A 6, okay. So a 6. And why is it a 6 instead of a 0? Okay, so you have some interest, but you're just not confident. What's making you interested? Okay, so the finances, it's costly for you to smoke. Anything else? And told that, and so you're concerned about health, told that it's good for your health, and so concerned about health. Great, great. So the focus of this item is to get the patient to self-generate the benefits. Okay, so even if they're really low, like a 2 or a 3, well, why isn't it a 0? Well, because there is something I want to get. I am concerned about my health, or I am concerned that my kids are exposed to tobacco, or that my pet's exposed to tobacco, or the costs, or I don't want the tobacco industry to control me anymore. I don't like the looks that people give me on the street. Whatever it is, they're self-generating it, which is very different from you saying, you need to quit, it's bad for your health, you're giving that money to the tobacco industry, you're letting them self-generate it, which is going to be much more meaningful. They're much more likely to remember it. Okay, how about that second one? How successful do you think you would be with quitting smoking if you quit now? You started with a 0. How successful do you think you would be with quitting smoking if you quit now? About a 5? Okay. What would we need to do to get you to a 10? Okay, so if you knew more about the benefits to quitting, then you think you'd be successful. Okay. Or others, what would it take to get you up to a 10 to feel like you'd be successful? Okay, knowing that the support getting you through this process. And then you can also ask the other way. So you said, tell me your number again. No, for successful. 5. All right, so it's a 5. Yeah, it's good. Anyway, right, so 5 and then going up higher to the 10, sorry. And that the purpose of this question is to look at the barriers. So what's getting in the way? What are the challenges? Okay, you said you're here. What do we need to do to get you up to a 10? And having them identify what the barriers are in the way, and that gives you the inroads for treatment. Well, I'm really concerned about withdrawal. I'm really concerned about weight gain. I'm really concerned that my roommate smokes. Okay, and that lets you know, all right, well, what interventions are going to be needed for this smoker? Because not every smoker needs the same package. It's tailoring it to fit what their needs are. Okay, seem doable? And you can ask these questions in less than 5 minutes. Okay, so going to the evidence base. The U.S. Tobacco Treatment Clinical Practice Guidelines, they were updated in 2008. And the literature base, the studies that they looked at in the literature, there was over 8,700 research articles that informed their clinical practice guidelines. Tobacco is just an amazing risk behavior, leading killer. It's also a great behavior for doing research on because, it's easy to measure, and there's a lot to be learned about helping people quit smoking, and then that can be generalized into other risk behaviors, be it physical activity or diet, and so on. So a lot of research has been done on smoking, and yet less than 30 were randomized clinical trials for treating tobacco dependence in smokers with mental illness or addictive disorders. Less than 30. 8,700 articles, less than 30 of those are randomized clinical trials, which is the best design for treating tobacco in the clients that we work with. And these are the individuals who are smoking at higher rates than the general population. Further, our clients are the most likely to be excluded from clinical trials, so mainstream clinical trials. They view our individuals as our clients as too complex. They're on psychotropics. Oh no, that's an exclusion. They had depression in the last year or suicidal ideation in the last year. Oh no, that's too complicated. So we don't know that much about how to effectively treat these individuals, and we don't know how they may differ or not differ from the general population. But I will share some really exciting data that's coming out. The research on tobacco and depression, the initial work was mostly done on people with a history of major depressive disorder. And these are studies that were done in freestanding smoking clinics. And what we saw was that there was greater tobacco abstinence if they were given psychological support. So if they were just given a medication, they didn't quit as well. If they were given medication with cognitive behavioral cessation treatment or in group support, much more likely to quit. If they had a history of major depressive disorder, they did much better with the psychological support than without. Individuals with a recurrent major depressive disorder, so if they'd had more than one major depressive episode, they were especially helped by cognitive behavioral treatment with mood management approaches. So some of our cessation programs incorporate mood management, so getting pleasant activities on board, challenging negative thinking, other ways to improve mood. And then there was individuals with a history of MDD may have more difficulty quitting and more severe withdrawal symptoms than those without MDD. So some indication in the literature that that might be the case, although it's not real consistent and clear. Found in some studies, but not others. And then there were these case reports that were published suggesting that those with a history of major depressive episodes may have a recurrence of an episode after quitting smoking. Okay, so a case report would be like a write-up that a researcher does on one individual saying, this individual was in my smoking cessation study, they quit smoking, they had a history of depression, and the next thing you know, they had another full-blown episode of depression. And there are these alarming case reports that, clearly, if you've got somebody who's not depressed and you take away their cigarettes and now they're severely depressed, that raises concern. And so it's understandable why this would raise concern. But with case studies, you don't have a clear sense of what's causing what. And we know with depression, there's a lot of relapsing risk with depression, okay? Especially somebody with a recurrent history of depression. So it's important to look at what's related to tobacco and what's just part of the natural course of the disease. So Glassman did a study. He had people with major depressive episode recurrence, and it was found that 6% of those who continued smoking had an MDE recurrence versus 31% of those who were abstinent. So much more, 5-fold greater risk of depression recurrence if they quit smoking than if they didn't. And this was published in a leading journal, so it raised concern. The problem was that there was a real differential loss of follow-up. 5% of the quitters were missing versus 39% of the continued smokers. So nearly all of the quitters were found and interviewed, and many of them had a recurrence of depression. A lot of the continued smokers were missing from the data, and of those they found, a smaller proportion had recurrence of depression. And so we don't know. It may have been that many of the people who continued to smoke and who were lost, 39% of the continued smokers were missing, 22. Many of these may have had a recurrence of depression, and so it wasn't counted. And it may be that this was much higher rather than just 2. It could have been many more out of the 22 had a recurrence of depression. A colleague of mine, she published this with data that we have at UCSF, looked to see if there was a relationship in the rate of recurrence of depression among those who were abstinent versus continued smoking, and she found no difference. She found a high rate of depression recurrence in the sample, but it wasn't related to whether they quit smoking or not. It was just related to whether they had had depression in the past. So this is a little technical with this stuff, but it's important to follow up with your data to be complete. Particularly, you don't want differential loss to follow up in your different groups, and then showing high rates of depression recurrence regardless of quitting smoking or not. And that depression's a remitting and relapsing disorder. Our group was the first to publish a clinical trial, randomized clinical trial, with currently depressed smokers. So most of the literature before had just been with a history of depression. This was the first to look at currently clinically depressed smokers. Can you help them with quitting smoking? And then we also looked, okay, if you help them with quitting smoking, does that have any harm on their recovery from depression? And this was done in the Bay Area, 322 depressed smokers, recruited from 4 outpatient psych clinics. This was not depression managed by primary care. This was depression warranting the need of a psychiatrist. The intervention was stage-tailored, so it matched their readiness to quit. They did not have to want to quit smoking to be in our study. If they decided that they wanted to quit smoking, they could get the nicotine patch. Here there was an expert system counseling intervention, so they sat down to a computer and asked them about their readiness to quit smoking, their beliefs and their ability to quit smoking, the pros and cons of quitting smoking, and their engagement in different strategies, processes for quitting smoking, like getting help from others, raising their awareness of harms of smoking, limiting their exposure to tobacco in the environment. The computer program gave them feedback and told them how they compare to other people in their stage of change. And then they did the computer again at 3, 6, and 12 months, and the computer told them how they changed over time. And they then would meet with the counselor for about 5 to 10 minutes to review the report that they got and assess, okay, are you interested in quitting now? If they were interested, they could then get nicotine patch from us, and they could get 6 months, with a 6-session individual counseling protocol. This was compared to a brief contact control where they were just offered referrals in the community. And these are the quit rates over time by group, the dark blue being the intervention group, this lighter blue being the control group, and significant differences at 12 and 18 months. We're not sure why the control group went up at 6 months, but this increasing curve of abstinence is very typical with stage-tailored interventions where you're engaging more people over time with quitting smoking. And this rate of 25% and 20% at 12 and 18 months looks just like what we see in the general population with these interventions when you're working with unmotivated to quit smokers. So no difference in terms of our clinically depressed smokers compared to the general population. So we looked to see if there's any relationship between depression severity and tobacco treatment outcome. There was no relationship, so depression severity as measured by the Beck was unrelated to participants' likelihood of quitting smoking. And among intervention participants, depression severity was unrelated to their likelihood of accepting the cessation counseling from us with the nicotine replacement. Next, we looked to see, well, did we do any harm? And we looked at this in a number of ways at a number of different time points because we really wanted to be comprehensive to see if there's at any point did we cause harm. Among depressed patients who quit smoking, there was no increase in suicidality. This was measured with the Beck, I think item number 9. Among those who quit smoking at the different time points, nobody endorsed that item. Compared to those who continued to smoke, about 1 to 4% endorsed that item at the different time points. And we did assessments at 3, 6, 12, and 18 months. There was no increase in psych hospitalization, 0 to 1% for those who quit versus about 2 to 3% among those who were smoking. We saw comparable improvements in the percent of days with emotional problems. No difference in use of marijuana, stimulants, or opiates. It's not like they were then compensating with other drugs of abuse. And there's actually less alcohol use among those who quit smoking. And this shows their Beck Depression Inventory scores over time. Everybody starting in the moderate range and then coming down over the 18-month study period with no difference in terms of their reduction in depressive symptoms based on whether they were smoking or quit. So it's not, helping them to quit smoking did not harm their depression recovery. And just to say, they were in treatment for depression, so they were getting treatment for the depression while they were getting treatment for quitting smoking, and that combination worked well. So to summarize, the stage-based tobacco treatment with cognitive behavioral treatment and nicotine replacement had significant effects at 12 and 18 months. There was no evidence of worsened psychiatric symptoms associated with quitting smoking, and smoking can be treated concurrent with depression without adverse effects to mental health functioning. The next study that we did, this was in inpatient psychiatry, and this is a study that I led with funding from NIDA. It's a smoke-free psych unit. We offered the same intervention, computer-delivered, stage-tailored. They were offered 10 weeks of nicotine patch, and that was compared to usual care where they were just given referrals. We enrolled 224 patients. They represented a full range of psychiatric diagnoses. And we recruited 79% of them. So we would go up to just about anybody on the unit as long as they smoked at least 5 cigarettes per day because we were offering nicotine replacement. And 79% of them said yes, that they would be in our study. And we were able to retain 82% of them at 18 months. So we followed them over time once they left the hospital, and we were able to maintain contact with 82% of them over that time. These are the quit rates by group. Significant at all time points and over time. For the intervention versus the control group, with 20% quit at 18 months compared to 9% in the control group. And then we looked to see, well, did we have any harm on their use of mental health services if we offered the treatment to them, if they got the treatment versus the control group. Our sample had a 46% rehospitalization rate. So over the 18-month period, 46% of our sample was rehospitalized in psychiatry, which sounded really high to me at first when I got that number. However, there's data for the state of California, and it's at 44% of people who are hospitalized are rehospitalized within a 12-month period. So 46% in an 18-month period, very comparable to 44% in a 12-month period. We had 232 rehospitalizations. It was unrelated to quit status. It was related to African American race, psychotic symptoms at baseline, lower income, prior psych hospitalizations, and treatment condition. And we controlled for all of these factors in a model, and it was still significantly greater for control versus treatment participants. So, I don't know what's going on there. This is the first study to ever show this. It definitely should be replicated. But at a minimum, we're not doing any harm, and potentially, there's some reduction in psych rehospitalizations. And then the 18-month quit rates and the pattern of increasing abstinence rates over time are consistent with prior investigations. So here's the initial study I showed you with depressed outpatients, here's with inpatient psychiatry, and then here's how it compares to the general population. So our depressed outpatients, our psych inpatients look no different in their ability to quit smoking with these interventions compared to the general population. That was in an academic medical hospital. We've since taken it to our county hospital with 100 patients, a little bit lower recruitment rate, but still pretty darn good for going into inpatient psychiatry and asking people to be in a smoking study. Similar in terms of age and gender, much more ethnic diversity, which is wonderful. Similar in education years. 81% have less than $20,000 per year income. 39% are homeless, and most are uninsured. So, really complicated patient population. Really high rates of substance use. Lots of psychotic symptoms. And here's the quit rates over time. So here's at San Francisco General Hospital, the intervention group compared to the standard care. Here's what we had at the academic hospital, Langley Porter, and these are because we only followed them out to 12 months because of the funding, just the number of years that we had with the study. But very similar, in fact, even higher in our county hospital. My postdoc, Norval Hickman, led this study, and I said, Norval, my goodness, what were you doing there to achieve such great rates? It's even higher than the general population. But also higher rates in the usual care group. So I was wondering what was going on to kind of bump those up. And here at this point, there was actually, I think, 8 or 10 individuals who were in a controlled environment. So they were in jail or a state hospital where they could not smoke. So this would likely come down to be closer to here for both groups. But again, real optimism there in terms of helping individuals who are dealing with a lot, and yet helping them with quitting smoking over time. The other point to make, I don't have the data here, but we look to see, is it that we help them stay smoke-free from their hospitalization, or is it that they went on to quit over time? And there really was no difference in terms of delaying their return to smoking from a smoke-free hospitalization. It's more that we were there as a resource for them, and that we would see them again at 3 and 6 months. They'd do the computer again, and we would say, okay, now would you like the nicotine replacement? Now are you ready to quit? And so really be keeping that in mind with the clients that you work with. It's not likely to be this one-time 5-10 minute intervention, and the next thing you know, they quit smoking. But it's planting that seed. It's again, letting them know you're a resource, that it's an important issue, and working with them over time till they get to a place where they feel that they're ready to quit smoking. In terms of treating smoking in patients with schizophrenia, there were some initial studies where they tried to tailor a group treatment. They had American Lung Association group treatment, and they tailored it to how they thought it should be appropriate or better fit for individuals with schizophrenia. And there's actually no difference. So tailoring it versus not tailoring it didn't make any difference in the quit rates. There is literature to show that those who are on atypical antipsychotics are more likely to quit than those on typical antipsychotics. Of course, you don't randomize. They haven't done any studies to randomize typical to atypical and see how people quit smoking. So it could be that the patients are different, but some consistent findings that atypical antipsychotics, it's easier to quit when you're on those versus typical. And then just last year, there was 2 meta-analyses published looking at interventions for quitting smoking tested in those with schizophrenia. And there were 6 randomized controlled trials that were done, 260 subjects total across the 6 studies. Most of the literature prior to these meta-analyses, it just kind of concluded, maybe you get an initial treatment effect, but the long-term effect is a wash, and that these patients they're not able to quit smoking at the long term. Problem is that these studies have been terribly underpowered. 19 subjects. The max was 59 subjects. Okay? You saw that initial data I was showing, 300 subjects, 200 subjects. If you don't have sizable, if your study's not properly powered, doesn't have a good enough sample size, don't do it, because you're not going to find a significant difference, and then you're going to conclude, well, there's no significant difference, it didn't work. The benefit of a meta-analysis is that you can combine the data across studies, and you can quantitatively do so and come up with a relative risk, a statistic that'll show you what's the likelihood of that person quitting, of a treatment effect rather, and you've got more power for detecting a difference. Okay, so 6 randomized controlled trials. At the end of treatment, the relative risk was 2.57. So there was a 2.6, 2.5 greater likelihood of quitting smoking in the treatment group versus the control group, and it was significant. So this is great. At 6-month follow-up, the relative risk was 2.78, even higher. Okay, 2.78 higher likelihood, so a 278% increase in the quitting among those in the treatment group versus the control group. And how does this compare to the general population? This is just with limited to bupropion, and now studies that use bupropion, so Wellbutrin or Zyban, and the other names for that. It was actually higher than the relative risk published for the general population. So it looks at bupropion for quitting smoking was found to be well tolerated in patients with schizophrenia who were stabilized in an adequate antipsychotic regimen, and it found even that the treatment effect was even greater in this group than in the general population. So this would be great, really important information to get out to psychiatrists. We are doing a training with psychiatrists in October to get this word out there. Have you guys heard of varenicline, Chantix? Some head nodding, okay. Just a little bit of the investigations of this drug in those with co-occurring disorders just now getting started, getting nothing really published yet in terms of randomized control trials. Eden Evans, who's a fantastic researcher at Harvard, published this. It's an open label case series with 13. She had 19 patients that she followed in an open label, so she was giving them varenicline as just part of her practice. She's a psychiatrist. And 13 of the 19 quit smoking at the end of treatment, 68%. That's just fantastic. She had 3 of the 19 stop the medication because of adverse effects, which were the nausea. And she didn't have anybody who had more psychosis or had to be hospitalized or anything like that. She has since been funded by NIDA, National Institute on Drug Abuse, to do a large randomized controlled trial to look at varenicline in smokers with schizophrenia. And then Pfizer has a study that they've just finished looking at varenicline with smokers with schizophrenia, as well as one that they have underway looking at varenicline with those with clinical depression. But if I'm going to mention varenicline and bupropion, I should also mention the black box warning. So there have been a number of case reports of individuals having behavioral disturbance when on varenicline, and also with bupropion. And the FDA did a review and decided to put black box warnings on both medications. And the advice is that patients should be advised to stop taking varenicline or bupropion and to contact a healthcare provider immediately if they experience agitation, depressed mood, and any changes in behavior that are not typical of nicotine withdrawal, or if they experience suicidal thoughts or behavior. So if you're working with a client who wants to quit smoking, varenicline is an option for them, or bupropion, but you definitely want to monitor any changes in behavior, and if they did have anything, you would advise them to immediately stop the drug. And more and more research is needed, particularly by NIH-funded studies. Tobacco cessation in schizophrenia symptoms. Again, Eden Evans' work looked at symptoms following tobacco abstinence. These were individuals with schizophrenia who were no longer smoking and were not on nicotine replacement. They were on bupropion. And being free from tobacco, being free from nicotine, was not associated with worsening of attention, verbal learning memory, working memory, or executive functioning, inhibition, or clinical symptoms of schizophrenia. So that belief that those with schizophrenia have to have nicotine in order to function, just not found in this study during a period of abstinence. Bupropion is associated with decreased negative symptoms of schizophrenia, and varenicline, no worsening clinical symptoms and a trend toward improved cognitive function on this medication. And then there's been just 2 published randomized clinical trials with clients with PTSD, both done by the same group, Miles McFall, who's in Oregon. This initial one was a pilot study, and then the next was a very large multi-site VA study, VA trial. This first one, randomized controlled trial, with 66 clients. They compared integrated care, which was manualized treatment delivered by PTSD clinicians and the case manager. These clinicians and case manager only received a 3-hour training. You know, you're getting a 3-hour training today. It did not have to be anything super extensive. They provided behavioral counseling once a week for 5 weeks plus 1 follow-up, and then cessation pharmacotherapy was available. And this was compared to usual care, which was referral to the VA smoking cessation clinic, which the clinics tend to be very, very good, but it was outside of their PTSD care, so it was, you know, requiring them to have to go to a different setting. In terms of cessation medication use, the integrated intervention, 94% of those people who were randomized to that used cessation medication, compared to 64% of those who were in usual care. For counseling sessions attended, much more likely to attend more sessions if they were integrated intervention versus usual care. And at all assessments, the odds of abstinence were 5 times greater for integrated care versus usual care, which was significant. And that led to the multi-site trial, which they just published in December in JAMA, with 943 clients from 10 VA medical centers. Integrated care, again, compared to usual care. They did a train-the-trainer model this time, where they brought in somebody from all of the 10 sites. They trained that individual. That individual went back to their home clinic and trained the providers in the PTSD clinic to then provide the intervention. And what do they find? Cessation outcomes, 2-fold increase in quitting, 6-month, 7-day point prevalence abstinence, nearly 17% in the integrated care compared to 7% in usual care. At 18 months, 18% integrated care to about 11% usual care. And the strongest predictor of treatment effect was the number of counseling sessions received. So it was even more predictive than the use of cessation pharmacotherapy. Having the counseling sessions, having that contact with the clinician who was addressing tobacco with them over time, that was the strongest predictor of quitting smoking. And they also found that quitting had no detriment on PTSD symptoms. So taking away tobacco did not hurt their recovery from PTSD. So to summarize, in general, the currently available interventions show effectiveness with smokers with co-occurring disorders. There's a wide range of abstinence rates with unknown determinants, so we just don't have enough literature out there to say, oh, well, this group does better with this, or that group does better with that. Definitely need more research. The evidence of a harmful effect on psychiatric symptoms or recurrence is weak, and integration to mental health treatment settings increases abstinence rates. Okay. How about tobacco among those with addictive disorders? And this is another meta-analysis. This is one that I published in JCCP, and we're actually looking to update it because there's been 10 studies published since we did this back in 2004. But at the time, there was 19 trials that were done, 12 tobacco treatment studies for those who were in current addictions treatment, 7 that were conducted with people who were in recovery, defined as being for at least a year. Our findings is that for the in-treatment studies, post-intervention abstinence rates were significantly higher for the intervention group versus the control group, 4-fold higher. This was significant. For those in recovery, post-treatment abstinence rates were 38% for the intervention versus 22% in the control. But that long-term follow-up, it was no longer significant. So they got a significant post-treatment effect for quitting smoking, but not at 6 months follow-up. And I think what was going on there is that back at the time that these studies were done, it was just too much caution. Tobacco's just not a part of addiction treatment settings. It's that last drug of abuse, let them use that, don't want to hurt their sobriety, so that they weren't offering the most intensive, best treatments that they could. And there actually was an indication that the more recently published studies had stronger effects, and so I'm hopeful that with this update we'll show better outcomes at longer-term follow-up. And these are the quit rates, which I just said. We also looked not only at quit rates, but also from tobacco, but also their sobriety over time to see, well, did being in a cessation intervention hurt their recovery in any way from other drugs of abuse? And actually, at the long-term follow-up, tobacco treatment, being randomized to a tobacco treatment intervention was associated with a 25% increased abstinence from alcohol and illicit drugs. So receiving a tobacco treatment intervention didn't hurt their recovery from alcohol and drugs. It actually was associated with a 25% increased likelihood of sobriety, which is very interesting and hopeful. There was one study that was done since the publishing of the review that we will be including now. It looked at delayed versus immediate cessation treatment and had comparable quitting smoking rates at 18 months, but a little bit lower 6-month prolonged abstinence rates. That was not among those who were offered immediate cessation treatment versus delayed, but that effect was no longer significant at 12 and 18 months. So a little bit of a hint of maybe the alcohol abstinence was better if they delayed tobacco cessation treatment, but at the 6-month follow-up, but actually there was no difference at 12 and 18 months. So still a lot of interesting work that can be done in this area, but generally showing that treating tobacco does not harm recovery from other drugs of abuse. There's another review that was done with 17 studies looking at smokers with current and past alcohol problems. Those with current and past alcohol problems were more nicotine dependent, less likely to quit in their lifetime, but when offered treatment were as able to quit smoking as individuals with no alcohol problems. So finding that it's more just access to treatment, being advised to care, being advised to quit, and provided treatment, and when they did, then they were just as likely to quit as those with no alcohol problems. Okay, so to summarize, in general, currently available interventions show some effectiveness, at least for the short term, in helping those with substance abuse problems quit smoking. Range of abstinence rates with unknown determinants. Weak evidence of a harmful effect on abstinence from illicit drugs and alcohol. And disorder-specific data may eventually allow better tailoring of treatments, but we need more research. And then prevention, right? So I'll just talk about this briefly. If you hear that the patient does not now use tobacco, never used tobacco, well, you might think, well, why would I even bring up not smoking? They've never smoked, so why even bother? This was a real interesting study done by colleagues at UCSF, and it was looking at Kaiser data. So Kaiser has a wonderful database for following people over time. And this was in their chemical dependency recovery program, the CDRP, and they followed people over 12 months. And they found that among those in the chemical dependency recovery program, there's nearly 650 of them, 13% of them who were smokers at baseline quit smoking. So they were in treatment for their addiction. 13% of them spontaneously quit smoking over a 12-month period because the CDRP didn't address tobacco with them at that time. 13% quit on their own, so that's great. However, 12% of the baseline non-smokers reported started smoking or relapsing to smoking. So it was a wash. Some of the smokers were quitting on their own, but some of the non-smokers were now smoking. Why was that happening? Well, the breaks, what were people doing? They were going out and smoking. They're quitting one drug, and maybe they'll start thinking, well, maybe cigarettes will keep me off that drug. Maybe they were encouraged to smoke by treatment providers. So, again, real concern about relapse risk, and so wanting to address with your clients. Well, that's great you're not smoking or that you're quit now. Let's see what we can do to optimize that to keep you from relapsing. And then just another anecdote is a participant in one of my studies. Met her on the inpatient psych unit, 63-year-old woman, and she said she'd just started smoking because we asked, when did you first start smoking regularly? And she said, now, at same age. And it's not part of our assessment, but I couldn't help asking, why did you just start smoking at the age of 63? And she said, well, I was down at a substance abuse treatment program down at San Luis Obispo, and everybody there was smoking. They were going out in breaks and smoking. They were out in the patio smoking. That's where all the socialization was going on, and so I started smoking. She goes, but I'm not going to continue. I won't continue. And she had already smoked more than 100 cigarettes, which is our definition in the field for a lifetime smoker. And we followed her over 3 months. This was an observation study, and followed her over 3 months, and she kept smoking. So, it's a very risky time for people, whether they come into inpatient psych or addiction treatment. They're vulnerable, and if we're not getting tobacco out of that setting, they're vulnerable to starting an addiction that really can have significant effects on them. Very little that's been done in terms of tobacco treatment in adolescents. This is just in the general literature. Only 48 published randomized controlled trials with adolescents. Again, if we talk about 8,700 clinical trials or studies feeding into the clinical practice guidelines, only 48 being randomized controlled trials with adolescent smokers. No clear successes with this population. Some promising approaches identified in this review: stage-based treatments, cognitive behavioral treatments, and multi-component treatments. Multi-component being like building in providers, schools, parents, so coming at it in multiple areas. Nicotine patch has been shown to be well tolerated and safe in use with adolescents and rarely abused among adolescents. But in general, cessation pharmacotherapy has not been shown to be clearly effective for adolescents, and it's actually it's not FDA approved for use with adolescents, so you have to have a provider write the prescription if you're going to use it. Also because of being under 18. This was one study that was done. This is the only study that's been done. This is the only published study that's been done with smokers, adolescent smokers who have mental health concerns. We have one that we've got data from, haven't published yet with outpatients. This is the only one published in the literature, and it was with inpatients. And they did randomized trial of motivational interviewing versus brief advice for smoking cessation. They had 2 45-minute sessions that were done on the unit and offered 8 weeks of nicotine replacement. Decent sample size, 191 youth, aged 13 to 17. The conclusion, there was no advantage of motivation interviewing in the smoking outcomes, but motivation interviewing was more likely to increase self-efficacy and intention to change in those with low intention. So really pretty low quit rates, no difference by treatment, but some indication that motivation interviewing could help with these earlier mediators of outcome. And then this one, treating tobacco with youth and addictions treatment. Do people, and I did hear working with families, do people work with youth here? Some? Or is it mostly adults? Adults? Yeah, okay, all right. So this is similar to what we found in the adult meta-analysis that tobacco cessation interventions appear to enhance substance abuse treatment outcomes rather than hurt outcomes. Tobacco. Okay, and now we'll do some vignettes. We're going to use the 5 A's, as I mentioned earlier, so asking about tobacco use, advising cessation, assessing readiness to quit, assisting, and arranging follow-up. And I want to hear from you guys, how would you work with this patient, and then I'll obviously give input as well. And then also considering what type of intervention based on the readiness of the patient will collapse the pre-contemplators, contemplators, and just focus on promoting motivation with those who are not ready to quit. For those who are ready to quit, behavioral counseling, pharmacotherapy, referrals, and so on. Okay, so the first case, and this is not her picture, this is, so there's no HIPAA violations going on here, and it's not her real name, but Vera. She's a 48-year-old divorced woman with being seen in a dual diagnosis treatment facility. She's got bipolar disorder, alcohol dependence, history of crack cocaine dependence, smokes a pack and a half a day. And she says to you, I'll likely die with a cigarette in my mouth. And she's having breathing problems. It seems like she might have emphysema. And you're working with her. What would we do with Vera? Okay, so advise her to quit. What kind of advice would you give her? How would you tailor it to her situation? Okay, so find out what other treatment she's in for her alcohol dependence or substance dependence. So find out what's working for her and try to get her to tie it together. Okay, good. So you're working, Vera, you're working on treating on your alcohol dependence, your crack dependence. We're really concerned about your sobriety in general. Tobacco is a drug like any other. Let's see how we can help you with that as well. Okay. Great. How else might you advise it and tailor it to her? What health issues are relevant to her? Her medications? Okay. So Vera, let's take a look at your psychiatric medications. There could be some psychotropics here that are being impacted by your smoking and maybe are not working as well as they could for you. Good. Great. So getting at that, well, that's, it's a really provocative statement that I'll likely die with a cigarette in my mouth. What is it? What's going on there? Are you trying to kill yourself with a cigarette in your mouth? Are you feeling hopeless about your smoking, that there's nothing you can do about it? Excellent. I wish we had you mic'd back there. So finding out what does she want to accomplish in her life between up to that moment, and is she going to be able to accomplish all that if she keeps going on the path that she's on, because it's going to curtail her life in a shorter way. Very good. Yep. You know, this woman, she did appear to have emphysema or COPD, and so really educating her about the course of COPD and that you can't reverse it, but the number one thing you can do to curtail it is by quitting smoking, and that many of the medications for COPD are not helpful in smokers, and so it is the number one thing that she can do for her health around her breathing is to quit smoking. Good. Her assessment of readiness to quit, where do you think Vera is at based on this statement? Do you think she's ready to quit? Okay, so I see heads shaking no. No. So not ready to quit, what kind of interventions would we start with then with Vera? Okay, I'm hearing suggestion, work on the other addictions first. Okay, what do people think about that? Okay, all right, another vote to try to work on them together and how they interact with each other. Okay. Excellent. So educating Vera that what you're going to learn for your other drugs of abuse are going to directly apply to your smoking. And so you can generalize them. You can use these and help you in different ways. And when you use them for smoking, you're just going to strengthen them so that you become even better at them when you use them for your other drugs of abuse. Mm-hmm. Great, great. So not only the coping skills for the substance use, but also for the bipolar disorder, for dealing with stress and mood management, are going to generalize those skills, same skills are generalized to tobacco. Excellent. When I work with smokers on the inpatient psych unit, they're getting DBT groups, so dialectical behavioral therapy. If you guys have some training in that as well. And I talk with them, you know, what you're learning for distress tolerance can apply directly to dealing with cravings for smoking. So like holding ice as a way to try to shift the focus. If you're feeling that intense need to smoke, go grab some ice and focus on the feeling and the sensation in your hands and having that help you break the moment that you're feeling. Good. Now, the concern, though, about wanting to wait to treat the other addiction, what's the feeling there? Because what's the concern there? Why wait? Or what? Mm-hmm. And then hopefully the learning process will apply to it. Mm-hmm. Okay, and I appreciate honesty, and you're not alone at all in feeling that way, in thinking that way. Mm-hmm. Okay, okay, and you've captured it. So because there's people listening as well, to just to rephrase, is that feeling like it'd be to be honest, it'd be the last thing you'd work on because she's got so much going on as there is, bipolar disorder, alcohol dependence, history of the crack cocaine dependence, and to bring in tobacco just seems like too much at this point. And hoping that things over time you'd have some a chance to work in the tobacco, or that it would generalize in some way. Okay, so once she learns that she's got coping skills, then you might bring in the tobacco higher than the alcohol or the crack cocaine dependence. Okay, I can understand that. We've done work with, Kim Norman does a group, a smoking cessation group in a homeless shelter with medical students who volunteer to do it. And there's this video, and it's really poignant. And it's individuals saying, you know what, I quit smoking, and that was the first thing that got me starting making other changes in my life. Next thing you know, I was getting some education, I got the job that I needed, and that's moving me forward. So for some, quitting smoking can be that catalyst, that change moment that can help them feel that they've got more control of their lives. So for some who've been struggling with depression or bipolar disorder and they feel like, you know what, I've been trying to manage this my whole life and I have struggled with it, here's something tobacco that I can actually make a change in and feel good about myself and I can see the difference, and then moving that forward is one. The other is there's another individual in the video who talks about, I know tobacco is bad for me, I know it's going to kill me, and if my doctor doesn't bring it up, I feel like my life isn't worth saving. Okay, and so that, just taking that moment and saying, you know what, I see that you're dealing with a lot right now, and I see that you're feeling hopeless with your smoking, but it's the number one thing you could do to help with your breathing. It has impacts on your psych medications, has impacts for your mood management, and when you're ready, I'm ready to work with you. So just not making that assumption, well, they're not ready. Let them know, I'll be ready when you're ready. And then moving them forward with that. Good. Okay, and then in terms, so we got the assistance. Okay, and what kind of, where would you leave things with her? So she's not ready to quit. You've kind of started trying to plant that seed with her, maybe educating her about how she can generalize what she's learning for her bipolar and addiction with this. What kind of next steps? Arranging follow-up, that last A. Where would you leave it with Vera? Great, great. So giving her the resources, giving her the phone number for the quit line, and letting her know that there's going to be ongoing resources for her when she's ready. Great, very good. Okay, Mr. Lee. This is based on an individual I worked with when I was a pre-doctoral intern in my training, and I was doing groups with veterans around quitting smoking. They all had co-occurring disorders. Many of them had schizophrenia. So this was a 75-year-old man living in a board and care at a city clinic, monthly med management. And he had schizoaffective disorder, depressed type, smokes 2 packs a day. And there was this, during the group that I was doing, the individual shared that he believed he needed to smoke to remember to breathe. And that if he didn't smoke, he might forget to breathe. And so in the real setting, so we're in a group treatment. This is what he shares. How would you work with this individual? Has he ever considered quitting smoking? Okay, all right. And he would say, I would say he'd say, I've considered it, but I don't think I can do it. I'm worried that I wouldn't be able to function. I wouldn't be able to breathe if I did. Okay. How about trying not to smoke? How about trying not to smoke and seeing if you remember to breathe? Okay. Very good. And that is actually where I started. I said, well, it's interesting because we're in a group setting now and you can't smoke in this room and yet you're still breathing. Yep. So doing a little bit of reality testing. Yep. Yep. How about what else with him? Okay, good. Okay, very good, very good. So the thinking is that maybe he's thinking that it's the nicotine that helps him to remember to breathe, and so having a cessation medication, would he consider using that? And there's the puffer, the nicotine inhaler that mimics the hand to mouth and the breathing in, so that could be a potential use for him. Yep, so straws, very good, thanks. Yeah.
With him spending that much money on cigarettes, 2 packs a day, and living in a board and care home, bring up that he's probably spending 75% of his discretionary income on that. And are there other things that he would like to do or spend money on?
Excellent, excellent. So quantifying how much he's spending on cigarettes, 2 packs a day, about 75% of his income is what you're anticipating giving he's in board and care, and talking with him about what would motivate him, what he could use that money for instead as a motivational tool. Great. In the back?
I think I would want to know if you involved the support system and, you know, I make sure that, I don't know, if his buddies at the board here also
Mhm.
support him and how he relates back to his socialization from his family, with his family. Because I think that those probably some challenges that the guy will help him overcome. So I
Mhm.
think it's
Excellent, excellent. So looking at the socialization, the social structure at the board and care, are his buddies smoking with him? Is the patio the prized place where everybody's hanging out? And what would that look like for him if you were to try to quit? Great. Mhm. Excellent, excellent. Yep, great, great. So to paraphrase for the people on the outside too, that may be where he congregates and finding other activities that he can do, particularly in those first couple of weeks when he's really at risk for relapse. Where is he going to go? Can he stay inside in the TV room? Can he go to the library? Can he go to a public park where there's no smoking, coffee shop? Because he's going to need to change that routine because he's going to be very vulnerable to being exposed to tobacco. Mm-hmm. 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 Great, great. So asking how long has he smoked and any health issues and with his age bracket and that kind of, great, good. Good. One of the other things we talked about with him is, well, what other things get him to breathe, makes him feeling breathe? And my guy actually wasn't 75 years old, but he said, well, when I run, then I breathe. And we said, well, maybe you could build on some exercise, and why don't you try that? And so, in between our sessions, he did try that, and he started actually running up hills because he really wanted to breathe. And said that it did, that he tested that hypothesis that he needed to smoke to breathe. He didn't, and this was another way that he could manage these feelings in a healthier way. Good. What would you, in terms of arranging follow-up with him? And I'll say he wasn't quite ready to quit smoking yet, but what kind of intermediary steps could you do with him? Mm-hmm. Yep, so check in with him on the city clinic monthly management visits, see how he's doing over time. You could have him do, if he felt comfortable doing that tracker to get a sense of just how much is he smoking. 2 packs a day is a lot, 40 cigarettes, and start to see which ones he might be able to get rid of that aren't that important to him. Make some inroads there. Good. Good. And then arranging follow-up. Yep, we've got that. We just said that. Okay. Ms. Jones, 64-year-old widowed woman, retired, seen for weekly psychotherapy visits, major depression and partial remission, smokes a half pack per day, concerned about smoking but pessimistic. And she is an individual who likes to smoke with her coffee in the morning and is feeling pretty isolated. She's widowed, and so she's concerned about smoking, thinks that she should quit, but she's feeling pessimistic about her ability to quit. What would you do with Ms. Jones? Mm-hmm. 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 Great, great. So using the mood log with her as a starting point, getting a picture of her day-to-day life. How much activities is she engaged in? What's her mood like? And how much is she smoking? Great. So some self-reflection for her to see it. Very good. Mm. Excellent, excellent. would like to have you mic'd as well. So talking about tapping into that pessimism and getting a better sense of what's behind that. Has she tried to quit in the past? What worked, but then what also led to relapse? And educating her about, educating her if she failed, like with pharmacotherapy, getting a sense of, well, what did she use before? Maybe it wasn't adequately dosed. Letting her know that there's new medications available could help with optimism as well. Mm-hmm. Excellent, excellent, excellent. So if I can recap that one, looking at her treatment for major depression, talking about how tobacco can fit in, and you actually could, consider like adding bupropion. If she's got concerns around mood, maybe bupropion could help with her mood and with quitting smoking. Seeing that the psychotherapist is on board and educated and helping with quitting smoking so that they're not discouraging it. And I know I missed one other one because there were several good things that you just said. Right. Great. That she's isolating and building in some supports and groups to get her out of the home, ideally smoke-free groups. And we do that with the trial that I do. Sometimes they get involved in the animal SPCA, kind of walking pets, or going to the library for computer classes. Nicotine Anonymous is definitely an option as well. Good referrals. And then you also mentioned the caffeine, that she's staying home and drinking the caffeine, and so wanting to educate her about that when she starts to reduce her smoking or quitting smoking, to adjust her caffeine as well. With Ms. Jones too, she's isolating and she's staying at home and drinking coffee and smoking, getting her into a coffee shop. Is there a place that she used to go to or a new place that she'd like to try? Because there's not going to be any smoking going on in there, and that could be a nice environment for her to kind of change her routine a little bit. Good. Mm-hmm. When we did the meta-analysis on the addiction treatment, we searched a database called Embase that will search internationally, foreign language, and we were all prepared to have translation done. Nothing found. There's been studies of psych units that have gone smoke-free, and a few of them have been international. And the studies have consistently shown, there was a review done by Long and Poles, Lawn and Poles, L-A-W-N and P-O-L-S, two different authors, did a review together, 26 studies, and they showed that going smoke-free, these inpatient psych units going smoke-free, did not have the negative consequences that were really anticipated. And that in particular, if there was a full smoking ban, not this kind of allowing, passes to go smoke or that kind of thing, that in particular, that went really well, that there wasn't higher PRN use or calls for security or use of seclusion. So those have been international, but treatment studies, no. NIH is so valuable in terms of funding science. I think that's a huge part of it, and then the U.S. has been so leading the way in addressing tobacco as well. No, it's good questions. In terms of secondhand smoke laws, that's definitely becoming more pervasive internationally. Like Ireland, I was in Ireland for a meeting 2 years ago, and there being no smoking in bars and restaurants, which is outstanding. Europe, France doing similarly. So there are progressive movements, but in terms of the randomized clinical trials, no. Okay, this is based on another case that I saw, young man who was hospitalized in our inpatient psych unit. He was hospitalized because he shoved his stepfather down a flight of stairs. He had explosive mood with paranoid delusions. Smoked a pack per day. He was interested in staying quit when he left the hospital, although he didn't want nicotine replacement. He just felt like he wanted his body to be free of nicotine. So what would you do with Doug? Mm-hmm. Okay, so combination of working with him in the hospital, but then setting up supports and treatment for when he leaves. And you're saying that right now he's saying he doesn't want any cessation medication, but giving him education and knowledge. Mm-hmm. Mm-hmm. Yep. If he doesn't want to, go ahead. Okay. Excellent, excellent. Mm-hmm. Excellent. So getting to him early. He's wanting to quit now. He's 17, doing it now, so not waiting 20 years of exposure to tobacco, finally to address it. Nearly all the harms of tobacco can be curbed if you get hitting at it really early. Social supports, you're saying, seeing where the parents are, pulling that in, and then looking at why he's using tobacco, how it relates to his explosive mood, and other healthier ways like exercise. All great suggestions. Mm-hmm. Great. So talking about his social network, and are there smokers, are there non-smokers who could support him with that? Doing work in the unit, you can do some role plays on how will you ask for support and get the support that you need from your circle. And then staying on his psych meds when he leaves, talking about adherence to his psych meds so that he's able to deal with his symptoms and that they won't trigger him to want to smoke. If he doesn't want nicotine replacement, you could consider something like bupropion or varenicline. You just would want to monitor him and see how he does. And the psych unit, starting the drug in the psych unit could be helpful because then you've got a period of monitoring while he's there. Mm-hmm. Mm-hmm. Great. So the financial aspects and the short-term, immediate appearance negative consequences of smoking. You're saying the discoloration of the nails, of the teeth, the smell, impotence can be something that could be of interest to a 17-year-old male. So getting at what are the negative consequences that are relevant to them? What are the benefits of quitting that are relevant to them, like the saving money? And then also you're saying make them aware of the long-term consequences too, so that they're aware. You could talk with them. Do you have a family member who smoked? Somebody who's important to you who's died of tobacco? What was that like as well? Mm-hmm.
looking at the whole person, what is important to them, what has their illness or their addiction taken from them, what are they missing, and finding a way to draw a path from where you are to where you want.
Mhm. Great, great. Taking a holistic approach, not looking at them as just a diagnosis, but seeing how everything fits together with who they are and where they want to be and how you can help optimize them to get to where they want to be and how tobacco is not consistent, perhaps, with that path. Excellent. Very good. And with him, he was in Kaiser, so we connected him with the Kaiser cessation program that they had. And it was an interesting case when I presented his case in treatment. I was his primary clinician, and I was an intern. I was very, very junior at UC as an intern, and presented the case to the team, multidisciplinary team, and the director of the unit, who's no longer the director of the unit, but at that time, he said, "Quit smoking. That's the last thing this guy needs to worry about." So you can kind of get a sense of what the environment was like organizationally at that time, and we can talk to him about making changes. This one, Ms. Allen, 34-year-old married woman, employed at intake. She's presenting for intake at outpatient mental health clinic. She has dysthymia with neurotic features, smokes 10 cigarettes per day, wants to quit smoking but recently failed, and has some concern about weight gain. And what would you recommend for her? Great, great. So assess her, have her talk about why she wants to quit. She's saying she wants to quit. What are the reasons now? So get her, open-ended questions to get her to dialogue about that. Great. Mm-hmm.
Well, because she appears to be ready, because she failed, so I will admit that, I think maybe talking to her about the different options, medication-wise, and supports, and she wants to quit. Her readiness is probably pretty good.
Mm-hmm.
And then she recently failed. She told me she failed and maybe put her in contact, like Ashland told her, other people with
Mm-hmm. Excellent, excellent. Looks like this might be the last one I need to summarize because there's a mic being activated in the back. Is that?
We're going to try the mic and hope we don't get feedback.
Okay, great, great. But I will summarize this one. So excellent. Saying she wants to quit, so wanting to move towards, really providing treatment, being active with her. One thing, recommended that when you have somebody who wants to quit, you want to set a quit date within the next 2 weeks, ideally, because they're ready to go. So getting that on place. You mentioned getting cessation medications in place, talking about the recent failed attempt, see did she use any cessation medications, what worked or what didn't, does a higher dose need to be used, maybe combination therapy be used, like more than one nicotine replacement or nicotine replacement with bupropion. And then you mentioned the support, getting the support into place, referring her to the ASH line, as well as other outside supports. Great.
Doug had family. Why were you not including more of the natural supports and the family supports? And that's something we haven't talked about. We keep talking about an outside line. Oh, well, then I'll stop talking. But just wanting to, get that supported.
Great, great. So great point. So married woman, finding out, does her spouse smoke? Is her spouse supportive of her quitting? How can she talk with her spouse and other network to get support in the way that she needs it? So not nagging support or not saying, oh, honey, you're so irritable now, maybe you do need a cigarette. But finding a way that she can communicate effectively with her support system to get the help that she needs. It's interesting, the clinical practice guidelines always recommended intra and extra support, so within treatment as well as outside of treatment support. And then the most recent guidelines suggested, well, maybe outside support isn't that helpful. And the problem is that the research has been pretty murky. So in some investigations, building support systems have been helpful, and others not. Excuse me. And it looks like we just got funded to develop a relapse prevention intervention using Twitter. And that was one of the criticisms that came from the review group, saying, well, what's the deal with social support? Is it helpful at all? And what we saw in the literature and how we responded is that when studies have taken existing support networks and tried to improve them in some ways, that hasn't really worked that well. But when they've taken and built in new support systems, whether it's like through quitline support or through groups that are formed for non-smokers and provided support in that way, that has been effective. And so that's where we're going to try to do Twitter, where smokers could get support at any time of the day from any place to help with maintaining staying quit. So, but thank you. Good. Mm-hmm.
The other thing is, she talks about, she's employed, and I mean, I have a friend that she's struggled with quitting smoking for a long time, but a lot of asking her about her employer, are they able to smoke? Is there a smoking place? I know my one friend told me it's getting harder and harder to smoke.
Mm-hmm.
Like, you can't smoke at an airport and all that. So just talking about her employment and would she feel better at work if she didn't smoke? I mean, just stuff like that, and if there's other things that can kind of take the place of that activity. So I'm always kind of into, like, if you exercise or run or you just do anything in place of that activity, then it might help you to use up the time, because some people describe cigarettes as kind of like their friend and stuff, and it's hard to give that up.
Great, great. So the employment situation, what is the employment situation around allowing people to smoke, the stress level around her employment, and so on. Great. Okay, we will keep going. We will do one more case, and then we'll talk about the organizational issues. So this is Tammy, and she's an 18-year-old single pregnant woman, county-funded. She's being seen at a county-funded women's care clinic. She has ADHD and also borderline intellectual functioning. She's reduced her smoking from 30 to 5 cigarettes per day. She wants to quit but feels she cannot reduce any further on her own. How would you help Tammy?
Oh, I really don't need that. Well, I've told out here. Once you learn that even 1 or 2 cigarettes and how much damage it can do to your lungs can usually be, a catalyst to actually finally quitting. Because once you get down to 5 cigarettes, you pretty much have figured you've accomplished, all you need to accomplish. So, even with supports, I would have to have another reason to quit the rest of the 5.
Okay, so building in supports, I'm hearing she's already done an amazing amount going from 30 to 5, so you'd really want to praise her for that, encourage her with that, ask her how she was able to do that reduction and what's been working for her, and then helping her to reduce. You're saying she's done all the hard work, it's now just getting rid of the 5, is your feeling? Uh-huh.
And just, I would help her understand the effect on her fetus
Mm-hmm. Yep.
with those 5 cigarettes.
Yep. So the advice here with a pregnant woman would be, tailoring it to her, which would be the fetal development. So when she smokes a cigarette, it's that smoke is robbing the baby of oxygen. So the blood binds more to the carbon monoxide than it does to the oxygen, and so that it's suffocating the fetus and harming the development, weight gain, and so on. So letting her know it's not only, number one thing you can do for your health, but also for the health of your baby.
And we can relate that health of the baby back to her own particular challenges. And would you want those challenges you had in your life for your child? So relate it back to her personal challenges, I think, might be more than just, this is going to hurt your kid and this is how. But do you want your child to live the same challenges you have?
Mm-hmm. Excellent, excellent. And there's research to show that in utero exposure of tobacco is associated with ADHD in adulthood, in childhood and adulthood. Yes. Would you consider pharmacotherapy with Tammy? Shaking. So I see some head shaking, some head nodding. So it's complicated. The FDA recommendation is actually that you start with a behavioral intervention first with pregnant women. But if they're not able to quit, and she's been reducing, if you're not able to quit, then you can consider nicotine replacement. So or ibuprofen. Varenicline, there's no data. Nicotine replacement, it's a Schedule Class D. So it has been shown to have nicotine has harmful effects. But the thing is, she's already giving her baby the nicotine through smoking, and at least with nicotine replacement, she wouldn't be exposing to the carbon monoxide. So for her, I would consider something that would be more short-acting, that she would just take when she needs it, like gum or lozenge, rather than slapping a patch on, because she's only smoking 5 cigarettes a day. It's just kind of having the gum or lozenge when she feels the real intense need to smoke. Lots of talk about social supports. With the other cases, definitely with her, you'd want to bring in who's in her life, who she's living with, if there's and how they can support her with quitting, and making sure that there's not other exposures to tobacco in the home. Making the home smoke-free would be really critical. Tobacco use in the home is the #1 predictor of SIDS in kids, and infant death syndrome. So you definitely would want to work to not only get her smoke-free when she's pregnant, but also post-delivery. Okay. All right, so we'll just summarize. Cessation counseling, you want to routinely identify tobacco users as they ask, strongly advise patients to quit, assess stage at each contact, tailor intervention messages by being a good listener, providing minimal intervention in absence of time for more intensive intervention, and then arranging follow-up and using the referral process if needed. This was the sticker that we created for putting on our progress notes at Langley Porter. We're still very much paper-based at our psych hospital, and this was a way to get the residents to have a quick, efficient way to start doing those 5 A's. And this is also a template that you can download for Xeroxing on like Avery labels or however through the RX for Change website. Mm-hmm. We do. It's a label that we then stick to the progress note, and our medical records team was okay as long as they signed below it. They're okay with this addition. Mm-hmm. This was, yep, so the question is who's responsible for asking about tobacco, and where did we have these labels? So now at Langley Porter, it's a couple different branches, but there's actually now we have an electronic health interview that all patients sit down to the computer. So that asks about tobacco along with other risk behaviors. This idea was because we wanted the 5 A's where they were going to assist and arrange follow-up, we had that with the providers. So these were psychiatry residents where we have them, they would put it on their progress note and then indicate how did they assist. Did they provide education? Did they look at the pros and cons? Did they do a mood log? Did they set a quit date? And they would just check that box. And then with arranging follow-up, what did they do? They prescribed NRT. They provide a referral to the quit line, and so on. Yep. Anybody. Mm-hmm. Yeah, and then we just made them available in our, where people picked up the charts and had progress notes. We just made these labels available so that they could just grab one and slap it on if they wanted to use it. Mm-hmm. Yeah, so you're saying there's a health risk assessment in your nursing, and the nurses ask the question. Yeah, so there's different ways to do it. We also have it on our intake form. Yep. Ideally, like with the VA system, they have it where they ask it every 3 months, and the computer program cues them to do so, which is just fantastic. And at Kaiser's gotten their smoking rate down to below 10%. And a colleague of mine, Stan Glantz, who does a lot of policy work, he's a real force to be reckoned with and well known. Every time he goes in for any care, like he had a broken ankle from hiking, he had his eyes checked, every time he goes into Kaiser, they ask him if he's a smoker. So, there are ways to definitely start to whittle away, and being really proactive and attentive to tobacco, I think, has really served Kaiser well with their population. This just shows you we did a chart review, 1,200 medical records. We trained the psychiatry residents. We gave them those labels for their progress notes. And this is what we found. This is their behavior at pre-training. This is 3 months post-training. in terms of increased in asking about tobacco. Here's increase in advising patients to quit smoking. Here's increases in assessing readiness to quit. So it's a plus 32 percentage points in assessing readiness to quit, bringing it up to about 37%. Increases in assisting and arranging follow-up. So, significant increases over time, although still we wish that this had been over 50%. And then these lower bars are the residents who we did not train, and they didn't look any difference over time, very small changes over time. So doing the training and then having this kind of real pretty simple addition can serve to impact behavior.